So in general, I just want you guys to assume that unless otherwise stated, patients have normal liver function and otherwise are completely capable of, let's say, getting a transplant from a psychosocial, financial, etc. So we'll just kind of assume all options are available for all these patients. And so I think a great way to start would be this first case right here. So as we see, we have a 60-year-old male. He does not have a history of cirrhosis. He has a biopsy-proven HCC. It's measuring 28 millimeters right here in the middle of segment 5, 6, somewhere in there. It's an LR5, but as I said, it's a biopsy-proven HCC. So if this was presented at your tumor board, what are you guys thinking?
Well, I guess I'll start off just with a general statement that, our goal is always, when possible, to pursue a curative option. And with a single lesion of this size, no cirrhosis, I would probably first be talking to our surgeons to see if they felt that it was surgically resectable.
Thank you, Heather. I'm flattered. I think that would be also certainly my approach would be surgery for a patient that's without cirrhosis that's got a moderate size HCC. I think the size being under 3 centimeters, one also has to consider the utility of thermal ablation, which is a nice durable option for patients who aren't surgical candidates or who aren't interested in surgery. But I think this particular case, is amenable, at least from the images that I see, it's certainly amenable to a surgical resection.
What sort of surgery would this require? Can you do a wedge for this, or would this require some sort of anatomic resection?
Yeah, I think you can do kind of a larger partial hepatectomy, wedge, or segmentectomy. I would have to see a few more images to really look at the vascular anatomy and see how that plays out. But I think you can do less than a lobectomy on this one.
Dr. Padia, if you were to see this patient, what sort of therapies would you offer?
So, I agree with these guys. They probably get offered some kind of curative intent therapy. And let's say they're not a surgical candidate for whatever reason, or let's say they choose they don't want it. When we're talking about this is easily amenable to a lot of local regional approaches. And so our preference has been to either do a thermal ablation, in our case, microwave ablation, or to do a radioembolization. In this case, I'd probably favor a thermal ablation for a couple of reasons. Number one, it's under 3 centimeters. It is well-defined, well-circumscribed. There doesn't seem to be infiltrative margins. It's also not subcapsular, so from a technical perspective, it's pretty straightforward. In terms of radioembolization, I think that's also a great option. The one downside is that you may have to cover your perfused territory in doing a Y90 in this case, maybe more than you think it is, because you're going to have to hit all that peripheral liver as well. My preference here would probably be to go with a thermal ablation as my first choice.
And how about systemic therapy? Any role here?
I think the concept of perioperative systemic therapy is interesting from a research perspective, and there's been some small studies that have suggested that neoadjuvant immunotherapy may be something that's coming in the future, and that's helpful for us to understand the disease biology of these patients, get them sort of a test of time on immunotherapy. We've seen some great responses, including complete responses in some of those folks. But in terms of where we're at in 2024, no real role for immunotherapy. This person has a small unifocal tumor, and the risk of recurrence, unless there were surprise features on the pathology, is probably low.
And small tumor, no cirrhosis, do we offer liver transplantation?
We would not typically pursue transplant for a case like this. Yeah.
Okay, great. So this patient met with both a surgeon and an interventionalist. They ended up choosing to go with thermal ablation, which they ended up having a complete response.
I'm a little bit hurt.
I'm sorry.
That conversation didn't go very well, apparently. Or maybe Sid is just more persuasive.
Yeah,
exactly.
Well, don't worry. Your time is coming.